How can we make the world better? By making ourselves better. The Dr. Joe Show explores how you can make positive personal change by using his groundbreaking and highly effective I Am approach to understand who we are and why we do what we do. Your small changes can have big effects.
Join us now for the Dr. Joe Show with Mark Stiles of Stiles Law and your host, Dr. Joe Schrand.
Stretch the kindness, brush with madness. Is it sadness or just a show? Then go, 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 go. Then go, 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 go. Then go, 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 go.
Larry's in the house on the Dr. Joe Show.
Well, that's a different opening.
Oh, yeah. It's a good one, though, Larry. It's a good one.
Larry.
Yeah, here we are live in studio, WATD.
Not Memorex.
Not Memorex. No, and not on Zoom. It's really nice. Nice to see everyone in person.
Yeah.
4D.
You know?
HD, 4D.
4D?
Like in reality.
No, I'm way over 40.
Yeah.
Yeah.
Knees to knees.
This is
and now your knees are good?
Great.
Oh, wow.
That's good.
They're like the bee's knees now.
That's good. You know, I saw a beehive that there were no doors. It was unbelievable. Get that? Unbelievable.
Oh, it went by quick.
Yeah, it did. It did.
Right over my head, actually.
My kids said to me, dad jokes. They said, Dad, stop punishing us. And I said, I'm so proud of you. Punishing.
Yes.
Yeah, it's good. Okay, so we've started our show tonight. How have you been, Mark?
Do you guys remember us?
Yeah.
Do you enjoy listening to us?
I hope so. Dr. Walley, are you on the line?
Hello, Dr. Joe.
Hello, Dr. Walley. It's so nice to hear your voice again. How have you been doing?
I'm good. I'm good. I'm good. I saw you earlier this week, which was really nice, and that was an intense but uplifting evening. And since then it's been good. I feel spring is in the air.
It's wonderful. It is. I'm just going to pitch this over to Mark so that he can read your bio. Could you please introduce our guest for tonight, Mark?
I would love to do that, Dr. Joe. Our next guest, I met him the other night. I met him at Mass Maritime when Dr. Joe was presenting his latest show for the Drug Story Theater on Narcan. I'm looking very much forward to discussing with Dr. Alexander Walley, who's an associate professor of medicine at Boston University School of Medicine. He's the director of the Boston Medical Center Addiction Medicine Fellowship Program. His research focuses on the medical complications of substance use, specifically HIV and overdose, and is an active investigator on clinical trials and cohort studies. He provides primary care and office-based addiction treatment for patients with HIV at Boston Medical Center and methadone maintenance treatment at healthcare resource centers. He is the medical director for the Massachusetts Department of Public Health's Opioid Overdose Prevention Pilot Program. This is going to be an amazing episode, folks. Please meet, once again, Dr. Alexander Walley.
Yay! Nice to have you here, Dr. Walley. So it was wonderful to see you on Tuesday. Just so folks know, Drug Story Theater, as Mark said, does have a new show. And we had a presentation of it at Mass Maritime, along with a panel discussion afterwards. And I was so honored that Dr. Walley was there to talk a lot about Narcan, naloxone, and how we're saving lives.
And I noticed that you all filmed that. I hope that's available for the general consumption. That was really, really well done. And I know it was the first that you ran. It almost felt like a dress rehearsal. It was like a what do they call it in the restaurant business? Like a quiet opening or and it was an intimate gathering, and the presentation by Heather and her team was spectacular. And the panel was so eye-opening with the DA, Robert Galabois, who I think we're going to have on the show in a couple of weeks to talk more about this in depth. It was so eye-opening. They were talking about a drug, Dr. Joe, that I've never even heard of.
Xylazine?
Yeah.
Yeah. Dr. Walley, you want to just educate some folks about xylazine for a moment?
Well, sure. So I think most people by now have heard of fentanyl. So fentanyl, I'll start with fentanyl and then we'll get to xylazine. So fentanyl is a synthetic opioid. It is very fast acting and very potent. So instead of many medications, opioid medications, we dose in milligrams, but fentanyl is so potent we dose it in micrograms when it's used in a medical setting. And it's often used in the ICU. It's used on ambulances for pain now. It's replaced morphine in many ambulances. But it has also taken over the illicit drug supply because it's so potent and it's synthetically made. So you can be made in a factory. It doesn't need to be grown, as an agricultural crop. It's become highly efficient way to get people opioids. And so, and it's very, very addictive. It's many people quote that it's 50 times stronger than heroin. And there really isn't much heroin anymore in Massachusetts. What's sold as heroin is actually fentanyl. And we're not new to that. Massachusetts started seeing fentanyl in the heroin supply back in 2013, which was ahead of a lot of other states. But this drug supply has not been the same since then. It continues to evolve. And really starting about 2023, a year ago, maybe late 2022, we started to see fentanyl mixed with xylazine. And xylazine is not a medication that is approved to be used in humans. It's approved to be used in large animals as a tranquilizer or a sedative. And it's been around for a long time, but it hasn't really been used as an illicit drug until more recently. And the place in the United States, in the continental United States, where it's kind of been around the longest is in Philadelphia. And so a lot of us are looking to the experience in Philadelphia to understand kind of how to help people who are getting xylazine. So the reason it is combined with fentanyl is because fentanyl's short acting and xylazine's longer acting. And so together they work to make the experience of using the drug, the euphoria and the sedation that comes with fentanyl use to make it last longer. The kind of street term to that is it gives the drug sample legs.
Yeah.
Giving it legs means it lasts longer.
Yeah.
And so, the problem is that together they synergize and they make it more sedating. The other issues, there's three other things that happen. For reasons we're not totally clear on, it has a vasoconstriction, so it shrinks the blood vessels, which results in ulcers, really severe wounds. And so we're seeing a lot of us in New England now are seeing wounds that we haven't seen before, particularly in people who are injecting, but not only people who are injecting. And then the second thing it does is it synergizes with the fentanyl to make overdose more severe and more common, even more common than it already was. We had a hard enough problem with fentanyl alone. And then lastly, it complicates the withdrawal syndrome. So that means when people are coming off of it, they have a synergistic discomfort that they already are having with the opioid withdrawal, and it makes it more difficult for us to treat people, to get them onto medications, to get them comfortable.
Right.
So anyway, that's maybe more than you wanted, Dr. Joe, but that's kind of where we're at with xylazine.
Yeah, no, it's a brutal addition to our fentanyl problem, and it really is. It's incredibly addictive. It makes withdrawal horrible. But one of the things that I must admit we are a little addicted to, I'm sorry, are our sponsors. So with that in mind, I would like to if I could just get a little bit of our sponsors, that would be great. And we'll be right back with the Dr. Joe Show.
Hey, folks, thank you for listening to the Dr. Joe Show. We've been investigating whether or not we want to bring sponsors into our podcast. What are your thoughts? Do you know somebody who might be a good partner with the Dr. Joe Show, who may want to align their product or service with the Dr. Joe Show? Think about it. Hi, Larry. Larry, are we back?
Yeah, I think so.
Larry's here. Dr. Joe, did you know Larry's here?
I've actually heard Larry. It's nice to have you here in the studio, Larry.
It's nice to be here.
Yeah.
Love that sweatshirt.
Yeah, he's got a Superman sweatshirt on, folks. It's really cool.
And the hoodie, it's a hoodie, so it actually looks like a cape kind of with the way the hoodie's down. You see this red behind him. It looks like he might simply save the world.
Well, I must say, we are actually talking with a superhero as well, not just Larry, but indeed. Dr. Walley is really one of my absolute heroes. You really are, because you have been able to help so many people, but also training so many people in how to manage addictions. Can you maybe talk a little bit about that training program that you have and how that came about?
Sure. So at the training program that you're referring to is an addiction medicine fellowship. So I'm a physician. So is Dr. Joe. When physicians are trained, they have to start by finishing college, then they go to medical school, usually for 4 years, and they have to pick a specialty. And that specialty is something like internal medicine, which I am, and psychiatry, which Dr. Joe is, pediatrics, obstetrics, etc. You have the option to go on for further training after that, and that's subspecialties, and those are called fellowships. And so addiction medicine is a subspecialty. You can go into it from any specialty, and so I'm going into it from internal medicine, and it's a 1 year of clinical training, and it's a relatively new subspecialty, surprising, because substance use and addiction are really old problems. But I think it's some sign of recognition that our culture is shifting a little bit to really think about addiction and substance use care as something that belongs in the house of medicine. Not only, of course, it's much more than a medical illness or a psychiatric illness. There's a lot of domains, but definitely in the medical world, we need to be able to understand how to use what we know about science to provide the best care we can to people who use substances. So that's really what Addiction Medicine Fellowship is about. There's also Addiction Psychiatry Fellowship, so psychiatrists can get this extra training. And then what we do is really try to provide scientific, evidence-based care to people who are interacting with the health system and use substances. So I've been able to. We first started our fellowship at Boston Medical Center in 2011. We trained over 20 addiction medicine subspecialists. Many of them have gone on to be leaders. It's the part of my work that I'm the most proud of. I actually am no longer, despite your intro, I'm no longer the fellowship director at Boston Medical Center. I'm very proud that one of our alumni, one of the fellows that I trained, Alyssa Peterkin, is now our fellowship director. I stay involved very much in the fellowship. I call myself the director of alumni affairs. Nice. And get to work with them, including today. I was at a case conference where one of the fellows was presenting a structured case with the lessons that they learned about trying to help a person around their pregnancy. So it's one of the most inspiring things I do. I find with teaching, you get a lot more than you give. And this is something in substance use, taking care of people who use substances. you can't do it isolated or alone. You need to be in a team, or I need to be in a team. I really, where I get a lot of my inspiration, beyond my patients, are the people that are coming into the field hoping to make a difference. There's nothing more sort of inspiring than that. So,
and that is how you and I met. I had the Castle program, and we were honored to be a site for training of Dr. Walley's fellows in addiction medicine, which really was a huge honor to be able to do that. Mark, did you want to?
Are there enough folks focusing their attention on addiction?
Well, no. There's a big gap in services and care for people who use substances nationwide. And so we don't have enough people, but we're getting more people. I think there is some reduction. So the stigma around, I think maybe I talked about this last time, but the stigma, and I'm sure you all talk about this, the stigma of people of drug use, we stigmatize drug use, that paints the people who use drugs as being stigmatized. Mm-hmm. And it's the field where not only does it go on to the people who use drugs, but in many cases, the people who work with people who use drugs get stigmatized. And the treatments, even the life-saving treatments, often get stigmatized. So there's just a pyramid of stigma. That, I think, is in some cases melting away. And there is, there's a lot of people that are mission-driven. Many people who've been affected in their own lives, both through their own lived experience or through the experience of their families, and they've seen the difference that good quality care can make. And so then that really, and coupled the difference it can make, but then coupled with all the need that is being unmet. And so we have a long way to go, but there are more and more people coming into the field. The people who are coming into the field are coming in for the right reasons. And they are not only making a difference using what we know, they're also innovating.
Cool.
So, that's another exciting thing about the field is it's the flip side of this terrible, terrible drug supply that we're facing, a toxic drug supply. It's forcing us to be creative and innovate and try to, find new ways to fix these evolving problems. And so that I think is some of the excitement in the field.
Can you share more around that? Innovation is such a wonderful word. I love it so much. I want to hear more. What do you see?
Yeah, I mean, there's a lot of different areas that I'm excited about. I mean, I'll just go over one, which is the naloxone thing. So naloxone is a medication. It's the antidote to an opioid overdose. It was really developed in the lab in the 60s and first started to be used to, in operating rooms to reverse the sedation in an operating room after an operation in the 70s, and then, started to be used in emergency situations. So it's been around. That's not innovative, but a lot of my inspiration is and what I work on is harm reduction, and almost all of the innovations in harm reduction actually come from the people who are most stigmatized, the people who use drugs themselves. They're isolated.
Before we go on, could you just explain harm reduction to our audience, because they may not understand what that really is?
Sure. Yeah. So harm reduction means, sunscreen is harm reduction. Seatbelts are harm reduction.
I see. Yeah.
Having a fire extinguisher in your kitchen is harm reduction. It's the acknowledgement that people are going to take risks, and that we need to do our best to keep people safe when they take those risks. So, it's a risk to go out and be out in the sun. So we put sunscreen on to mitigate that risk, because and same when we drive in the car, when we put seatbelts on, we do it because driving the car can be dangerous, and a seatbelt can keep us safe.
I'm just going to say there's one risk really that I am not willing to take, and that is alienating our sponsors. So I'm going to have my own little bit of harm reduction right now. Larry, let's take a commercial break. We'll be right back with Dr. Walley.
Hey, folks, welcome back. So any thoughts? Do you listen to other podcasts? Do you see how they do the sponsors? Is there a way that they're utilizing sponsors that you enjoy or you don't enjoy? I listen to SmartList, and I really enjoy how the co-hosts share the voiceover for the product or service. It's really funny for the most part, but it's unique. It's them really endorsing. Does that work? What do you think? Oh, thank you, Larry. We're back, ladies and gentlemen, with the Dr. Joe Show, and there's no like weird transformation in technology when we're on Zoom and we're doing it live on Zoom and it's overlaid and it's weird. We're here, not Memorex.
Yeah,
we're innovating.
Nice. It's nice. We are. And that's really what we were talking about. We were talking about the naloxone, which is life-saving, which is part of what we were trying to, talk about with Drugs-Free Theater. But Dr. Walley, where else are we with innovation? I mean, we have this problem.
Well, can we hold on? Can we stay there on naloxone?
Sure.
Because what was really fascinating about your presentation at the Mass Maritime on May 7th, which is Opioid Awareness Day, right? The annual fentanyl.
Yeah, Fentanyl Awareness Day.
Fentanyl Awareness Day is the conversation around Narcan.
Mm-hmm.
And the need to have that harm reducer. Am I right with the proper statement of harm reducer?
Yep.
Available for everybody, just in case.
Yeah. So, I was sort of saying it started in a lab, then it went to the operating room, then it went to the emergency medical system. And then really in the 90s, people who use drugs themselves started underground and actually, frankly, illegally getting naloxone and handing it out amongst themselves.
Wow.
And saving each other.
Wow.
And it was really starting with a guy named Dan Bigg out of Chicago and the Chicago Recovery Alliance in the mid-1990s. He had a way to get the naloxone, and he distributed it among the social networks of people who use drugs. And then it was taken up by harm reduction organizations. And, that was innovation. We had in Massachusetts a mini fentanyl outbreak in eastern Massachusetts in 2004 through 2006. And at that point in Boston, most of the ambulances in the city of Boston didn't carry naloxone. But during that little fentanyl outbreak they had, all the ambulances started carrying it. And then the harm reduction programs in Boston started getting it. And then the overdoses started increasing. And so there was recognition at the state level. And that's when I got involved. I was drafted because they needed a doctor to sign a standing order and to provide some medical advice to the program. So that was my role back then. And I've sort of continued in that role. But it really took off from there. We had not just harm reduction programs that started wanting to pass this out, but parents groups like Learn to Cope, which is a really great organization here in Massachusetts that's statewide, and then police officers and firefighters. And now you're seeing naloxone posted, in public places, like in these things that can be called nalox boxes, where, they're handed out to the public. There's some libraries that offer it. And more and more what we talked about Tuesday night was trying to get it into the schools. It's no longer illegal. This is completely mainstream and endorsed by all the major professional organizations. And so that's like a innovation and implementation. And really, I think that has gone a long way in helping reduce stigma. So that's the innovation around naloxone.
How has that reduced stigma, do you think?
Well, for one thing, it puts the focus on keeping people alive.
Yes.
And one of the things I think is really key is not, being humble and sticking with the concept that every life is worth living. every life is worth living. And by making naloxone accessible, it is a message that everybody deserves to be saved.
Very, very good point. And it's so important that we are destigmatizing this. As you've heard me say, addiction is not about morality, it's about mortality. And naloxone, folks, it is so easy to use. That's the part that's really great.
It's not like an EKG machine.
Not an EKG machine.
You don't need instructions.
You don't have to inject it in someone. How can we educate folks just how easy it is to use?
Well, there's now an over-the-counter version. You can, I have no relationship to any of the pharmaceutical companies. But you can buy it at Amazon or Walmart online or at CVS or Walgreens now. It's not actually behind the counter, but you can buy the over-the-counter version for about $45 for 2 doses. If you want to have your insurance pay for it, just ask the pharmacist. Most insurance plans in Massachusetts do cover it, and many without a copay. So it's easy to get is the first point. You got to have it if you're going to use it. And then if you see somebody who is overdosing, and they're reducing their breathing, right, so that they can't get enough oxygen to their brain, and they're turning blue, then that's the time to first try to wake them up. But then if they won't wake up, then you administer naloxone. It's a nasal spray, a single push nasal spray. If you're comfortable doing mouth to mouth or rescue breathing, if you've been trained in that, then that's the next step to get that oxygen to the brain. And if the first dose of naloxone doesn't improve the situation so that they're breathing again, then you can give a second dose of naloxone after about 2 to 3 minutes. In the meantime, call for help and get help on the way. And that's how it works. It's as easy as placing it in the nose, pushing the button, and then getting help.
Yeah, and I do think your point that it is a component of destigmatization is really, really important. I hadn't really considered it that way, but you're absolutely right. The fact that insurance companies now are saying, "Hey, we'll pay for this because we want to save lives," is really important. I'm just curious, just to back up hundreds of years maybe, how do you think this stigma about addiction, substance use, alcohol, opioids, how do you think that all started? Why are we so stigmatizing of people who are using drugs and alcohol?
Wow, that's a good question. I think, undoubtedly one of the issues in the 20th century has been around racism. And so you hear the idea of war on drugs and mass incarceration. The way that the ultimate stigmatization is criminalization.
Yes.
Okay. So that's what we do. And some things need to be criminalized and therefore stigmatized. But when you're stigmatizing a behavior that doesn't directly hurt anyone else. Now, people may say, "Oh, well, because of the drug use of my family member, it destroyed our family," right? And they took from us, right? That is a tragedy that has really hurt a lot of families. But the criminalizing the actual use and not the behaviors, like, for example, stealing or stealing was probably the best example, right? That a lot of people steal because of their addiction, and I believe we should criminalize theft. Like, that's part of a civil society. But the behavior that leads to the stealing, the answer there is not, in my view, is not criminalizing it. It's actually a lot of what you talk about, Dr. Joe, which is like connection, right? It's like, rather it's supporting people rather than punishing them, right? That's another harm reduction motto, which is, support, don't punish.
I mean, one of my phrases is addiction is not a crime, but can lead to them.
That's right. That's right.
And one of the crimes is that we stigmatize people with addiction. I mean, that really is. Sorry, go on.
Well, I was just saying with if you look at the way that the criminalization has affected people, yet it has not affected all people the same way, based solely on their drug use. When I brought up the racism, I'm talking about when you mix drug use with being a race that has been minoritized or has been has been historically discriminated against, then that's really where the power of that criminalization, really has affected some of us more than others. And, it turns out that usually we're talking about Black and Latino and Indigenous people. They actually, on a population level, don't use drugs more than white people, for example, but they get criminalized a lot more often. And that is, that's part of the history of our society. Unfortunately, I feel I'm hopeful that we're moving in the right direction, and we're seeing a lot of that with some of the reform. But you asked where that stigma comes from. That's one of the places. I just also think that we have this independent streak in American culture that expects people to pull themselves up by their bootstraps and, be able to manage their own business, so to speak. But I think when it comes to substance use and the development of addiction in the brain, we think of it popularly as a moral issue, and it's really a brain chemistry issue, which is, I'm going to hand off to you, Dr. Joe, because I think that's a lot about what you talk about. Well, it's the same thing as you're saying. It's not about morality; it's about mortality.
Exactly. Yeah, and that really is what we're trying to teach in Drug Story Theater, where we try to educate folks about what's happening in the brain. And there's nothing you can do about it. I mean, it's really fascinating if you think about it from an evolutionary point of view, that we would have a brain that is susceptible to addiction. I mean, that alone is a really interesting conversation about why is our brain adapted like that? Well, it has to do with pleasure. There are certain things that are incredibly pleasurable. If you saw a mango tree and you remembered where that mango tree was for the next year, you would be able to survive a bit more than somebody who didn't. Memory happens to be more or less in the same place of the brain as where addictions live. So we have evolved a way to experience pleasure. I don't think there's anything wrong with that. Mark, did you want to add something in?
Well, Drug Story Theater, harm reduction.
Yeah.
Right? Innovative harm reduction. Get to them first. Right?
Yeah.
Get to that adolescent brain. Help them understand peer-to-peer what happens if.
Right.
You don't want to guess.
Right. And why give away your really cool brain?
Right.
I mean, that's really what Drug Story Theater is trying to teach is you have an amazing brain. Why would you want to give that away? Because I've heard so often, look what you've lost because you did drugs. And my point is you didn't lose anything. You gave it away and you can take it back. You can take it back. And what gives me the greatest amount of happiness, the oxytocin happiness, is knowing how much our sponsors give back to us. So with that, we will take a commercial break, hear from our giving sponsors, but we're going to come back with Dr. Walley and continue this, I think, really important discussion. We'll be right back.
Hey, welcome back. And again, we're super grateful for you listening to the Dr. Joe Show. If you have anyone that you think might be a good sponsor, shoot us an email at drjoepodcast@gmail.com. DRJOE podcast@gmail.com. Give us your thoughts about the show, too. We're wondering, are we talking to the trees or are people really gaining value in this? Please let us know. Thank you again and enjoy the rest of the show. Superman, are we back? We are back, Superman. with that beautiful cape. We're back with the Dr. Joe Show with Dr. Alex Walley talking about a very important topic. And part of it comes around innovation and open thinking. And, you know, we've had guests on the show that talk about it's not outside the box. There is no box. There are no rules. We're going to figure this thing out together. And one of the things that you said, Dr. Walley, that kind of pushed me back in my chair was the stigma is being lowered, reduced because of the acceptance of Narcan, because everybody's now starting to see the human being, because every life has a purpose. Every life has value, as opposed to in the shadows, in the alleys, in the dark. Milnia Cass Boulevard, you don't look too close because the face is blurry. It's not really human. And here with the Narcan, of course, we all agree, save the life if you can.
Yeah.
I think. So I think what you're saying is so profound.
Well, thank you. I mean, the other message that's in there is that, or maybe it's the same, but is that, you know, we need to really reach out and be connected with each other. You know, I want to stay on the innovation and inspiration, but the thing I worry about is, I know of people close to me who have died of overdose with naloxone in the same room. And the problem is that there was nobody there to give it to them.
Yes, that's true.
So naloxone doesn't work unless somebody's there.
Right.
And we're at a stage now, actually. So naloxone, to me, it's a medication. It's an antidote. It works. And really, I do believe everybody needs to have it. And we also need to reach out and connect with each other. Not over 90% of the people who are now dying from overdose were alone when they used the drug that killed them. And so this is really the problem right now. So naloxone is important, but if you talk about innovation, it's not enough. It doesn't. There's more we can do, which is to really help each other have a safety plan, right? And part of that safety plan is naloxone, but a big part of that safety plan is having somebody there with us when we're taking that risk.
And so that means we need to create these spaces for people, acknowledging, you know, that the harm reduction here is, we would love it if you weren't using heroin or fentanyl or an opioid. But if you are going to use it, let us at least be nearby. So should you overdose, we can save your life. And I wonder, you know, the same thing with, you know, with needle exchange and being sure that people have clean needles so they're not, you know, sharing needles and getting HIV and other needle-borne illnesses. But here, I think, is a major controversy, because I think here people say, wait, why should we spend our tax dollars in harm reduction and promoting this? Believe me, I am all for having safe spaces for people to use. In order to do that, we need to have them come out of the shadows and know that we're not going to judge them. But a lot of people are not seeing things the way you and I do, or my co-host Mark.
Right. And I will say that now I'm going to bring in a little science, which is that these safe spaces, also known as overdose prevention centers, they are widely accepted in other countries like Canada. I went to Switzerland this past year. I had the privilege. A lot of people talk about Portugal and Australia and Canada. So the development of these programs has the science behind it. But one of the implementation pieces is, for these to be successfully implemented, you really do need buy-in from the community. And that means the community that's around that space, the police, the law enforcement, and the businesses, and you need to build that trust. It turns out that there's a mutual interest among all of those folks that these programs can really serve. It turns out that when you implement these programs, when they're properly funded and staffed, they actually make the neighborhood safer.
Wow.
They make it feel safer, and they make it actually safer. And what do I mean by safer? I mean, there's less public drug use, right? Because people can go and use inside. That means there's less chaos outside. There's less drug trash. And the police, rather than, what's happening in Boston and many cities right now is, neighbors, I think in some cases appropriately, are asking for their neighborhood to be made to feel more safe. Well, where do the police push people? They either arrest people or they push them down the road to the next neighborhood. And so, that doesn't really take care of the problem. What we need is a place where people can go and feel safe and get support rather than punishment. That's the drug consumption spaces. And the Massachusetts legislature are looking at these right now, and we need the legislature to buy in. That's another thing. And many communities, including Somerville, and now Worcester, actually, the Worcester Public Health Department has just endorsed overdose prevention centers. So some communities are really coming around to this. And I think we're farther along in Massachusetts than we've ever been.
It's very encouraging. Very encouraging.
Yes. I do want to plug one other thing when we get to innovation, which is we have technology now, and not everyone is always going to be able or always going to be willing to go to one of these spaces when they exist. And so one of the things the health department launched a year ago, which I am involved in through my work at the health department, is the Massachusetts Overdose Prevention Helpline. And this is a service, a phone number that's available 24/7. It's staffed by trained operators, many of whom have lived or living experience themselves. And a person who is using opioids or other drugs, who's worried about that supply, who doesn't feel comfortable reaching out to somebody to be with them, they can call this number and the person will make a safety plan with them on the phone and stay on the line with them until they are safe.
And can you share that number? Do we know that number?
Absolutely. Hold on a second.
And while you're doing that, when you said I am involved in this, it really did spark the I am. And Mark reminded me that we do need to ask you the two questions. So as you're looking for that, I'm going to pitch the first question. As you know, in the I am approach, we're doing the best we can, but we're influenced by and responding to 4 domains: our home domain, the social domain, the biological domain, and the IC, how I see myself, how I think other people see me. Because these domains interact, a small change can have a big effect. We don't need to change everything. When we do some Narcan, naloxone, that's a small change that can have a big effect. So, Dr. Walley, given our topic tonight, what small change can you recommend to our listeners?
Well, it's the first thing that comes to my mind, Joe, is hug the people you love. And many of us maybe are already doing that, but I don't think you can do that enough.
Yeah. I absolutely agree. Hug those people, because you're then actually increasing a chemical called oxytocin, not OxyContin. You are reminding someone of their value with that hug. I think that's a wonderful small change. We can do that today, folks. You can do that right now after you listen to the show. The second truth of the I am, before we get to that phone number, is everyone's got one. Everyone is interested through their IC domain, the way you see them, which you know has an effect on their biological domain, because it feels different when you feel respected or disrespected. And because we are part of someone's home or social domain, the second truth of the I am, you control no one, you influence everyone. You get to choose the kind of influence you want to be. Dr. Alexander Walley, what kind of influence do you want to be?
Well, I want to support. I don't want to punish, and I want to get out of the way and let people really blossom.
And how do we do that? How do we get out of people's way, making sure that they're still alive?
Yes. Well, you have to really listen, find out where they find their selves, where they find who they are, and you stick with them. I guess this is something that I learned from one of my colleagues, Mary Wheeler. She said, you got to love people until they're ready to love themselves.
That's powerful. And it's so true. And so many folks who are struggling with addiction, they don't love themselves. And then that perpetuates the next use. Why bother? Why bother trying to get happiness when at least I can feel this temporary pleasure? And that's the loop. That's the loop. And the shame that goes along with it. It's just horrible. Dr. Walley, do you have that phone number that we can post?
Yes, I do. And it's 1-800-972-0590.
1-800.
Say it one more time.
Yes.
1-800-972-0590. It's open 24/7. It's completely publicly funded, staffed by trained operators, and you can call them just to say hello.
Dr. Walley, thank you so much for those life-saving words, and I truly appreciate you. You're giving me a hug from across the state. Thank you, Dr. Walley.
Thank you, Dr. Walley.
Thank you both.
Thanks. Bye.
Good night.
Good night. Good night, Larry.
Go, 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 go. Then go, 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 go. Then go,